Okay, so we have one question from Liliana Escobar. And she asked, are you familiar with any training system for healthcare personnel to better prepare them for handling these situations and there be reduced negative reactions from the patients and their family? A very interesting question. Actually, I don't know if one of the speakers or two or all of you want to say something regarding this.
Well, I don't know. I'm sure that our colleagues from Canada or Canada have some very good ideas and experience. First of all, Liliana, I'm Jose Mira from Spain. It's my pleasure to meet you again. Thank you so much for following this webinar. It's a pleasure to know about you. Well, I agree with Paulo. This is the core question, because of course the people who have the key to the open disclosure are the professionals. So if they are not able to open this procedure, maybe this is the main barrier and the main challenge in our organization. Specifically about your questions, there are some structured training for professionals. Of course, this is not a guarantee that all the meeting with patients are right, are good, and are happy for both. But at the same time, I think it's the best manner to train and to overcome the natural fear of barriers of worries about this situation. But I would like also to include, I am not, if my colleagues in this webinar agree with me, but your question, Liliana, is depending of the legal scheme as well in our countries, because it's not the same in the countries that there is a no-fault system that in others in which we must go through a litigation to compensate the patients or the families. This is the situation in your country, like me in Spain and in many others in Europe, but it's not the same around the world. There are a few experiences, and I think that the training and the duties for the professionals must be taken into account the legal scheme that are around the compensation for patients. But at the same time, I think that the experience from our colleagues from Canada is excellent, because it's, at my best knowledge, is the most innovative manner to cope with this situation, and in this case is to promote, to talk, to open talk about the emotions and about the situation, to meet an encounter between patients, families, and professionals. So I think that we need to consider several guidelines. I need to consider some legal schemes, and of course to design a training to support professionals to open and honest information after adverse events. I don't know if my colleagues of this webinar want to amplify this response.
Wendy, please, you raise your hand.
Yeah, thank you. Yes. You know, when I see this question, I think in the ideal world, during the professionals training at university or wherever they're situated, and with communication skills and understanding people, this should be fundamental in the whole issue of the relationship that one establishes as a healthcare professional, whether nurse, physician, physiotherapist, and to learn some skills in that regard. I expect that is incredibly variable depending on the country, the culture, the system. But I think we have to start, as health professionals are developing their knowledge, experience, wisdom, there need to be some fundamentals that are communicated from the word go. I think the challenge is someone who graduated 10, 20, 30 years ago. There's also a need to what is that training? And there should be something to enable them to develop confidence, ability in how to do this effectively. But I'll turn it over to Diane. I think, Diane, you may have some thoughts as well. Thank you.
Yeah, thank you, Wendy. I always have a thought too. I agree with Jose that often the training around disclosure is about how to be careful when you're disclosing. That's what a lot of the training is in Canada anyway, where the Canadian Medical Protective Association is the main they're not an insurance company, but they're the main insurer for legal issues or health for physicians. And they will say, when you're disclosing, make sure you say you're sorry, but don't take the blame. And here's some things you can do, which is helpful for the physician, but not always for the patients and families, because as Wendy was saying, there's that genuineness that you're missing when a physician or a nurse or a pharmacist is being very careful. So on the one hand, you have that training. And during my research, I did not find a training program for how to talk to patients after harm. This is very relevant. I'm glad you asked the question. And this is part of what we want to develop for the Mutual Healing Program. But if I do have some, I'll forward it on to the organizers, and hopefully they can forward it on to you, because I have something in my head that I did find. So I will try to do that after the webinar.
Yes, I don't know, Wendy, Paulo and Diane, if you have a similar experience, but at least in Spain, our data and our experience is that professionals usually imagine that the open and honest information to the first patients is the hardest. It's a mountain, it's an enormous wall. But really, professionals who have a first experience, the second and the third is more simple than they imagine. So training is needed, but as well to train to do, because of course it's a complex situation. This is not simple. This is not a very, very simple situation. Of course, there are emotions behind this conversation, but really, in many cases, at least in my experience, the imagine of most of the professional is like an enormous challenge, but really many times it's more simple because patients understand the situation and only want honest information and to her apologize about what happened.
Yeah, Jose, I completely agree with you. Here in Portugal is the same. I believe that in parallel to this kind of trainings and courses, the daily experience is crucial. Okay, so before we move on to other questions, let me just share with you all an information that we have here. We have greetings from several countries, including Spain, Portugal, Estonia, Brazil, Peru, Mexico, Turkey, Germany, and Austria so far. So we have another question from Diana Rodriguez Hurtado, and she asked what percentage of these problems arrive to legal situation. So another very interesting question. I don't know which of you want to?
Well, in Spain, some of our studies is about 17% in Spain some years ago. But really, it depends on the countries, because it depends on the customs, of the legal schemes, and it's very, very difficult, at least for me, to say a specific figure, because it's not the same in United States, probably in Canada, Japan, or others. In Spain, there is a growing number of litigation, but really only a few progress. And in this case, the data of 70% is the patient receiving open disclosure, and in this case, decided to open a litigation. In this case, our figure is around 70%.
Okay, probably Wendy or Diane or Kaya. Do you want? Oh, sorry, Diane, you raise your hand. Sorry.
That's okay. Thank you. Yes, in Canada, what you've got to realize, I think it's 2% of physicians will be named in a legal action throughout 2 to 4% throughout their lives. So it's very small in that sense. But you have to realize also that even if you're named in a legal action, it doesn't mean, like a lot in our case, I don't know if that's the same way across the world, but in our case, many healthcare workers are named in a legal action all at once so that it captures everyone just in case. And then as the time goes on, people are dropped off so that there are only 1 or 2 left at the end. So even if you're named in a legal action, it doesn't mean it's the end of the world for you, but it is very traumatizing to be named, or very anxiety ridden. But it's not as common as we're led to think. I'd love to hear from Kaya. I know you have a lot of the stats too.
Yeah, speaking about Estonia, we don't have reliable data about that because we also don't have a formal open disclosure system, and I think we believe exactly to this part of health professionals where it depends on the institution and health professional how all this process is organized, because there are no common guidelines, and how many are legal processes. There are every year some of them, but how many are resulted from open disclosure, or how many are resulted from the situation where patient is not getting a proper information from healthcare provider, we don't know, because they don't have had this kind of research. But coming back to the previous question, training about open disclosure and legal framework, I think that these 2 things have to be at the same time simultaneously, because the legal framework does not help only if the professionals don't know how to act in the situation where the open disclosure is needed. And at the same time, until the legal framework is not supporting, there is actually no big use to teach the health professionals how you should act in this situation, because they cannot practice that in real life. And if they try, they may have very serious legal consequences. So 2 things at the same time, legal support and training at the same time, how to act. Thank you.
I would like to highlight, Paulo, that there are not a lot, of course, because the research on this topic is not a scarcity, but it is not the most relevant topic, of course, in the patient safety research. But there are many results of the research suggesting that to introduce open disclosure is reducing the number of litigation, are increasing the results in terms of preventable adverse events, are positive consequences in terms of patient satisfaction and professional satisfaction as well. So I think that there is enough evidence that there is not only in the negative side of the coins, is also to see the positive side of the coin. And in this case, there is a fruitful intervention to train professionals, to introduce guidelines to open this type of procedures in our healthcare institutions. And maybe this is related with other of the question on the chat from Veronika Pakutova from Slovakia, because this is as well a very, very key question. And what we can do to introduce open disclosure, because it's a procedure that maybe is directly related to the patient safety culture in our organizations. So I think that it's not only to introduce disclosure, in my opinion, because disclosure is part of the culture of the organization. Of course, we can introduce a mandatory guideline, but in this case, the attitude of the professionals might be to be defensive and not proactive. So maybe we need to think in terms of culture, but I don't know, Diana, Wendy, Caja, Paulo, what are your thoughts about this question?
Well, let me just say that in Portugal, as in Estonia, we don't have reliable data regarding this, but we have some very good experiences in disclosure information after an adverse event in some hospitals, but it's not generalized to whole hospitals or healthcare institutions across the country. I don't know if you should move to the third question or if you want to add something regarding this last one. No? So we have a question from Jose. I think you already mentioned this third question from Veronica.
Yes.
But let me put that as Veronica asked us here, and how to manage a situation in which healthcare workers or family are reluctant to open disclosure information.
I'll jump in and then I think look to the rest of you. But I want to pick up a point that Jose mentioned, and that is culture. And the culture of the organization is absolutely critical to enabling this to happen. You can have healthcare workers who are prepared to disclose, who perhaps have the personal skills to do so, et cetera, et cetera. But if the culture of the organization is or is not focused on patient safety, transparency, openness, providing support where needed to both patients, families, and the healthcare workers, then it's going to be an immense problem. And the overall culture of the organization, so that goes to the board, the body that actually is responsible for the hospital or the clinic or whatever it is, to the CEO, the chief medical staff, head of nursing. What is that culture of safety, and how do you know if it's present or not? And how do you develop it and nurture it and sustain it? So the culture of an organization, to me, is fundamental to being a foundation, but also a support system to enabling this to happen. And this can't be done without, it can be, but it's not going to be as effective as if the culture isn't brought along. I'd like to probably default to Diane if there's reluctance here, because I know that was a discussion we've previously had.
Yeah, for sure. So when you talk about culture, it's not necessarily the CEO saying we have a just culture here and it's open. It's actually that those personal conversations maybe a supervisor has with the nurses to say, when we make a mistake, everybody makes mistakes, and I've made a mistake myself, and you're not necessarily to blame. It's often a system error. So don't be afraid to talk about it, because we will talk about it together. We won't blame, we won't judge. So it's that supervisor creating that culture, and perhaps the director of that supervisor creating that culture. So it's something that grows organically from conversations, not necessarily something that comes from way above. And the other thing you were mentioning about if they're reluctant, I think you mean like if family are reluctant to have these conversations. it may take the families a long time to be able to go back. They might be so immersed in their own grief that they can't handle having that conversation. They're not ready to face the healthcare worker who might have harmed their loved one. So it may take years, but I think the organization has to be open to that, to say, okay, you're not ready now, and that's fine, but please come back to us anytime, years from now, if you still want to have that conversation. Same thing with the healthcare worker. And the example I mentioned earlier with the healthcare worker resident who maybe wasn't ready to talk to the gentleman whose heart stopped during surgery. It is just too traumatic to be able to talk, but maybe 5 years down the road, he would have been ready. Those are my 2 cents.
No, I fully agree with your thoughts. And it is very curious because if we are thinking that we have some questions from Latin America, some questions from different parts from Europe, our speakers in this webinar are from both sides of the Atlantic Ocean, and we are talking in the same language. We are talking about the same things, and this is a human factor behind our conversation. So some of the questions that we are receiving is regarding this human factor and how to overcome these natural barriers, but is at least almost mandatory for the professional healthcare workers, because it's an ethical point of view to open an honest information about what happened. So, but it's very curious because it's a lot of people talking about the same from many, many different parts, different national culture, different legal framework, and in many aspects, we are talking the same music. So it's very, very curious. Thanks.
So, Jose, taking in what you have been saying, let me tell you that reinforce that we, even though we are from different countries and even different continents, we are sharing here the same problems, which means probably that some solutions could be applied to different contexts. And so these kind of webinars and these kind of sessions are very important for us to learn from each other. Before we move to another question, I agree with what Wendy said regarding the crucial role of safety culture, but I would like to ask if the health literacy level of patients also could imply in the way of the disclosure should be done. What do you think about this, Wendy?
Well, I would say, first of all, that I think how it's done is going to vary probably in every situation. There might be, whether it's impacted by culture, whether it's impacted by the nature of the people involved, whether it's impacted by that patient and family and the type of incident. So I think no two disclosure. I think the goal of disclosure is fundamentally the same, and the intent is the same. But I think the how, I think definitely you have to be sensitive to what's the appropriate manner in this situation. Understanding, I mean, just going in and speaking to someone, you need to understand their background a bit. You need to hopefully have spoken with them previously and have a bit of understanding and rapport with them, etc. So I think to me, there's not a magic bullet. I think it's there's probably some guidelines, a framework around the intent, but just as you say, depending on perhaps literacy issues, cultural issues, other circumstances that have occurred, are there other stresses and tragedies in that individual's life that are impacting at the same time, and being sensitive to those things and what that can mean to the quality of the discussion. Because Because the problem is if the discussion does not go well, then we've made the situation worse and potentially added to the trauma. So it can't be taken lightly and needs to be handled in a extremely skillful way to truly get the outcome and the result which would be intended.
Okay, thank you, Wendy. And let's move on to another very interesting question from Vanessa Neves. And she asked, how about the role of universities in preparing students to deal with these situations? In your countries, are they taking steps to address this issue? And this is a very important and interesting question, which addresses not only the importance to give training and to have training and educational programs for those healthcare workers that are now in the front line, but also make us aware of the new generation of healthcare professionals and the importance to include this kind of topics in the undergraduate classes. So I don't know, probably Jose, you want to take the floor?
Well, thank you, Paulo. Well, one of the studies that the EARTH Consortium in Europe has conducted is regarding what happened about open disclosure, about second victims, and other specific patient safety issues in our universities. In this case, unfortunately, the results are not so good, and there are some close, and we need to improve our approach in our universities. My experience in this case, I am professor in a medical school in the Miguel Hernández University in Alicante, and this week there are 3 sessions in which many of my students are introducing open disclosure in a context in which we are all the control. I use usually actors to simulate patient professional encounters. Actors are trained to ask in different manners to represent a typical situation in which professionals must inform patients about adverse events. And first, students are trained to overcome these situations, and it's very stimulating because for them it's a different manner, and of course we are following open disclosure guidelines about critical issues that they must follow to inform these patients, these simulated patients, and well, I think it's a good experience. My experience with this type of approach is very positive, and they understand and introduce themselves in how to introduce honest information to the patients. They represent a typical situation, surgery, in ambulatory appointments and so on. So I think it's great. But really is, I think that is not very common in many universities. But well, it's my experience. I don't know in other countries.
Well, I can give the experience here in Portugal, mainly in my university at the National School of Public Health. We are a post-graduation school, and we have some modules, not specific, focus on disclosure contents, but dedicated to patient safety as a whole, and of course covering some issues about disclosure, safety culture, what we should do after an adverse event's occurrence, etc. I don't know, Kaya, Wendy, Diane, if you want to share your experience. Kaya, please.
Yes, thank you. We in our university, which is the only university in Estonia with the Faculty of Medicine and where we train the future doctors. Last year we introduced in the third year students within the discipline fundamentals of diagnostics, also the concept of patient safety, just to understand what are errors, why they happen, what is systemic approach, so on. And also for the fifth year students, we introduced the patient safety, but also a little bit already safety culture. And we also talk a little bit about what is second victim. But yes, open disclosure, I think it will be in the future. So just it's not a different separate module or different course, but we'll try to integrate in the clinical disciplines, teaching together clinical subjects and also essential aspects of patient safety. But for the nurses in nursing master degree studies, we have actually a separate module, quality management and patient safety, which is altogether free European credits, 72 hours. So nurses are well trained, better than doctors now.
Okay, thank you, Kaya, Wendy, and Diane, because I know you are also linked to universities. So Wendy, please.
Get myself off mute, sorry about that. Yeah, I'm actually involved with CACMS, which is the Committee on Accreditation in Medical Schools here in Canada. And likely you have something similar in Europe, but there are standards established for, now this is medical schools, not what's required in nursing and the other professions, but I'm sure there are similar standards that are identified. And within those standards, we identify some specifics about what the learning environment is like, the leadership and planning, curriculum content is identified. There's curriculum management and evaluation. But I'm scrolling through this as I'm speaking to you. And of interest, I don't actually see the word patient safety. So in the curriculum piece, there's about biomedical, behavioral, social sciences, scientific method, critical judgment, problem solving, etc. And I know previously when the issue of patient safety in curriculums came up, and I'm looking back 5-10 years ago, the initial reaction was we can't add anything else to the curriculum. Like, how are we going to fit in more content, or what needs to come out to put it in, or how do you thread it through to be effective? So I think we still have a way to go. I'm pleased this question in this topic has come up, because I think I'll take it back to our next meeting and discuss a little bit about some specificity around patient safety specifically. So the standards are at a level where it'll still be up to the medical school to determine their approach, and similar to what perhaps Jose mentioned, which would be, I think, quite effective. Diane?
Yeah, that's what I was going to say, Wendy, that it's how to thread this kind of topic into a very packed curriculum. There was a lot of work done at the Canadian Patient Safety Institute, which was that organization before it merged with Healthcare Excellence Canada. So a lot of work done on the competencies, key competencies for patient safety. So there is a very thorough and excellent document about what those competencies are. And when they did that work, this is exactly what they found, that the universities did not have a lot of those on their curriculum. So the challenge is finding the time, right? And making it a priority. You know that if it's made a priority, they will find a time. But one thing they are making a priority, more and more is wellness. So wellness for the healthcare worker. And I think there's a way to insert the communications and understanding their own emotions, understanding what they're going through, talking about the patients at the same time. I think there's a way to integrate some of this work, some of these competencies into wellness. Just a thought. But thank you for that question.
Okay, thank you very much. We are arriving at the end, but we have here 2 more questions that I will put together in order to save time. And the first one comes from Italy. And it says, in Italy, we have legislation and training on open communication of adverse events. We still lack education at the pedigree level, and workload is a barrier. So this is one question. The second one from Diana Rodriguez is, what is the role of the auditory office of the hospitals in front of these situations? So I don't know which of one want to reply to one of these or the 2 questions. Jose, you are muted, sorry.
Yes. Sorry. Sorry. Well, I think that Italy has, well, it's not recent, but really is an innovation in the legal scheme in Europe about patient safety, and is a step go ahead that in other countries we have no similar legislation on patient safety. So really, Italy in this sense is a very good example, because it's a national regulation, not only about open disclosure, but just is about many relevant issues regarding patient safety, and specifically the relationship between patients and professionals. So I think it's a very good example. But really, there is scarcity experiences in the education level about how to introduce not only open disclosure, of course, this is clear, but I think that is more relevant in terms that is about patient safety in general. So there are most experiences in postgraduate, but not in graduate students. And the question from Diana Rodriguez is about the auditory office. At least to my best knowledge, this is a specific office in some countries, but not is a common office for all hospitals in Europe or Latin America and so on. So in many cases, for example, in terms of second victims, the idea to audit what happened maybe is contrary in some cases, because we need to know what happened. This is clear, but at the same time, the office who is auditing what happened in case of adverse event is collecting information to resolve. In some cases, for example, from France, I don't know if some of the participants in the webinar are from France. There is a very good experience, because this type of office is collecting information to produce solution to avoid the same adverse event in the future, or is integrating patients and professionals to meet an agreement about who is the best in each case. But in general, it depends on the attitude and the work that this auditory office is conducting, that we need to integrate in the discourse of the patient safety.
Okay. Does any of the other speakers want to comment on one of these questions? Wendy, please.
One quick statement I would make is, I think when we're trying to change practice and behavior and move forward, often having legislation and or a policy and or some sort of requirement is almost the first step to start moving the system. And then we start being able to get a swell of, how do we address this? What are we going to do with it? How will we move? So I think it's not unexpected that, it can take a while to get the actual required change in place, but I think there is a role for legislation or within an organization for a particular policy or requirement, which then necessitates the need to say, okay, what training is required? How are we going to put this in place? How do we deal with it effectively? So it is a step in this whole process.
I'm assuming that by auditory office, you mean the office that does the audits of adverse events? Am I understanding that correctly?
I think so.
Yeah.
So. That not only, but it's one of the activities, at least
Yeah.
in my best knowledge, but it's not a common office in many hospitals in many countries.
Yeah. So just a comment, if that's what is meant by that, one thing those auditing the adverse event can do is make sure that they don't re-traumatize the healthcare worker who has made the mistake. So bringing them together and debriefing in a whole big group and saying, well, what did you do wrong, is going to re-traumatize that healthcare worker. So their role would be to make sure that they're not laying the blame, especially before all the facts are known. That's one role I see in all of this. And I'm sorry if that's not what you meant, Diana, but that's my thoughts.
Well, the discussion has been very interesting, but I think we run out of time. And Jose, before give the last word to you to close, let me just say and share that I sincerely hope that you all and all the attendees have enjoyed to attend this webinar as we enjoyed to organize it. So thank you very much. Wendy, Diane, Kaya, and Jose, from my side, thank you very much. It was a pleasure to be here. I learned a lot in this webinar, and now I will give the floor to Jose, and thank you very much for inviting me to this webinar.
Paulo, thank you so much. Kaja, Diane, and Wendy. I fully appreciate your contribution, your time, and your experience and expertise standing with us during this webinar. On behalf of the AIR Consortium, I would like to say thanks to the COAST Association for funding this webinar, to all the attendees to follow this type of activities that we are organizing with the idea to improve the quality of care that the patients are receiving in our countries. So thank you so much to all, and just to invite you to follow our activities in the future. Thank you so much. Bye-bye.